Is TMS permanent?
After doing thousands of patients, right, the difference is going to be on each person.
Have you ever heard that TMS doesn't work?
Of course, sometimes TMS does not work.
Does TMS cause seizures?
And there is a probability, there is a chance.
All right, everybody. Kyle Hartfield here with I Talk TMS. I'm joined by a very special guest today, and I'm really excited about this. Dr. Weber out of Colorado, the #1 provider of TMS in Colorado. Dr. Weber, I want to thank you first off before we get started. Thank you for gracing us with your time and your knowledge. It's a very important topic, and I just really want to get into it. So first things first, Doc, tell me what excites you about TMS.
Pretty much everything. And thanks for having me. Like I said, I really do appreciate all your videos, and I really like how you really approach TMS. And so I appreciate this opportunity. Thank you so much. So yeah, TMS, pretty much everything. I'm trained adult. I've seen kids. I'm addiction trained as well. I spent 27 years in uniform, so I got trained by the military. Thanks for paying your taxes. Appreciate that.
Thank you for your service.
Yes, sir. Yes, sir. So, I have a particular aspect that I've had this training, but I've always had this block in the sense of trying to get TMS in the military, trying to get ECT, trying to get the military to do anything that was outside the box was a little bit difficult and challenging at times. However, I retired in 2016, and I got the chance to start this practice with my wife. My wife is a family practice doc. We've been together for 25 years. We went to med school together. So I did flight surgery and psych. So I was a flight surgeon before psychiatry. And then I went to psychiatry, and then she was a family practice doc. And so we started this with her focus was more on addiction with the Suboxone before Norphine.
Okay.
Yep. So she was helping augment that with myself. And then I was doing a holistic aspect of outpatient. So I wanted TMS, but I wanted the medications. I wanted the talk therapy. I thought biologically, psychologically, socially, spiritually, this is how we get people better, right?
Yeah.
And I could not find a better biological leg to that other than TMS. I mean, when you look at the literature and with the side effect profile being so minimal, with the amount of efficacy there, I thought it was untapped. And most of my medications, are poison or poison light, right? I mean, they do work. They do have their place. I still prescribe. I still see patients.
Okay.
However, I'm not a fan of big pharma, so I'll go ahead and throw that out there right away.
Amen. Amen.
In that sense, I think that we've really had a travesty that we forget about those other aspects, the psychological, social, and spiritual aspect. I mean, it can't be all just meds. And I actually don't believe it can't be all just TMS. That TMS will reduce those symptoms in such a dramatic way, other than the medications, that then we can take advantage of those other ones. And we actually move on those. We have outcomes measurements. We have value-based kind of approach here at Family Care Center. And that's what we're really focusing on is how do we get the patient better to get them into those other aspects of their life? I want them out of the chair. I want them off the meds. I want them through therapy, and I want them to have a better life. TMS does that.
That's amazing, doctor. That is amazing. So when we look up what's going on the internet and what people are searching for in regards to TMS, one of the most common questions we're getting is TMS safe?
Safer than any of my meds, right? So, the side effect profile of a slight headache, some palpitations in the head that, from the tapping, those go away. And actually, I have a protocol, and I think most people that have practiced for a while, we do a ramping kind of protocol. So we don't even usually have those.
Yes.
The seizure risk is so rare. I think the last study I looked was 1 in 30,000. There's a popular game system that has a higher seizure risk if you play it than TMS. I mean, it is.
Wow. I haven't heard that one.
Yeah. Oh, yeah. So if you look at a lot of things that can induce seizures, have you ever seen one of those movies that like this has a lot of strobe lights or photophobic, this could induce a seizure? Those things actually can. TMS has not. So
wow.
I mean, TMS can. It's a very, very rare side effect. I think we
have to give that disclaimer, right?
Oh yeah. There is a rare chance. And I do have a BrainsWay. So probably BrainsWay has the highest percentage chance. So I've tried 3 different machines. I also have an EEG directed. I do a very personalized approach
Okay.
to the way that we do TMS here. And actually, we just published because I use a bilateral approach as well as different level hertzes. And so I don't believe that just 1 hertz or
Yeah.
1 frequency is what you need. And so we really make it very, very personalized. And after doing thousands of these, and I've overseen over 35,000, and I think my practice maybe 120,000 treatments,
Wow.
so
Wow.
in aggregate. And so, it's been, when you can see a lot of these things, the bell-shaped curve starts to look, a little bit different. And then you can start piecing things together on how we can actually personalize this for each patient. It's very, very safe.
That's
In fact,
amazing.
I'll just give this, my wife said I could say it. I practiced on my wife. So when I was first learning, I was mapping and remapping her and treating her, and she's
I
doing
love
great.
it. I
She's doing
love it. When I'll add, when I went through TMS, my biggest thing was I'm gonna get so much better, and my wife's gonna be left in the dust, man. I gotta get her in a chair too, right?
Exactly.
So she's gotten treatment. My kids have gotten TMS. We're a TMS family, so no, I totally appreciate you sharing that one. A large question a lot of people ask: how does TMS even work, right?
Sure. So, there's you can look at the origins, or we could talk a little bit about the physics, right? Faraday's law, magnetic current creates electric charge. There's some we can geek out a little bit, but in general, an electric current really has trouble getting through your skull, your calvera, right?
Mhm.
A magnet passes through it like butter. And so as it kind of goes through, then I can actually have those changes on a neuronal level. I mean, we are a biological chemical machine up there with the neurons. And so how do I change those neurons, right? And so we can wait until BDNF, which is brain-derived neurotrophic factor, just naturally happens. We have neuroplasticity, occupational health, speech therapy, all these things, trying a new instrument. There's a lot of ways we can train our brain to have a rerouting or an augmentation of our neurons. But if I could supercharge it in such a way that meds can't really do it, that is what TMS is doing. So TMS takes this magnetic current, which then creates a very, very small, electric current on both a pre and a postsynaptic. And so when you look at the things with my meds, right, a reuptake inhibitor, right, an SSRI, right?
Yeah.
It's usually just on the back end, the postsynaptic. But what they're not taking account of is a neural network. And so to me, the thing that even the TMS, they're trying to do a lot of things pinpointed and more of a sniper. It's not actually a sniper. It's pretty much a shotgun, right? So
Right.
you have to look at the neural network that you're doing. And I can really only excite. And so I can excite. So there's a lot of literature out there, and I know the prevailing wisdom is, well, low hertz is going to be, inhibitory. Well, low hertz does, but what it does is it turns on the off switch of the neural network of the inhibitory, but it's still turning on something. It doesn't really turn off things. I don't knock somebody out because of TMS, right? And so that electrical current then is going to turn on that neural network. And so it's the location, it's the amplitude, it's the frequency. When I couple all those things together and put them in the right location based on the person's symptoms, based on their EEG or their electrical activity that's going on in their brain, we can actually help that neuroplasticity work in a way that's tremendously different than anything else. And so there's only 3 things that really release that BDNF, or brain-derived neurotrophic factor, that thing that lays new neurons down. And those are ketamine, which goes away very quickly, right? I did have a ketamine business for about 3 years. I do believe it has a place, especially in emergent, but it goes away very, very quickly. ECT, which then has a lot of side effects, still has an efficacy, has a bad rap, right? Bad in the eyes of the public, but it still has a place. And then TMS. So those 3 things release the BDNF, and it can start new neuronal growth happening right away.
That's actually perfect. It leads me right into my next question: is TMS permanent?
Well, I would say it depends. It depends. So after doing thousands of patients, right, the difference is going to be on each person and also what's going on. So I have seen, if you look at the literature and on the FDA, they'll say, well, in 6 months to a year, you might need a booster. I'll tell you right now, and it's going to be a subject of another paper that we're writing, right? And is that actually I try to couple it with the ECT tapering protocol. So when I do a tapering protocol, then I actually am kind of we built up that aspect to keep as much durability as possible. We've done that 30 to 35 sessions. Some people need a little bit more. And some people need less, right? I have people that have responded in 9 to 10 sessions, right? Yep. But in that sense, to keep that durability, I think that the tapering aspect really helps. And I tell you, in now 7 years, I don't think I've ever done the booster sessions because I've done this tapering protocol. And sometimes I do see somebody in 6 months to a year. It's rare. Usually it's at 1 to 3 years. And then there are some patients I never see again. I do have, if you've looked at some of my videos, that I do present one particular patient that I've gotten her off some meds and I've gotten her, in a much better place, no inpatient admissions for the last 5 years, but she does come back every 2.5 months for one session. And so this is where that personalized durability, what does that mean? And then of course, there are some patients that I never see again. I've gotten them off their meds or I've got them on lower meds or lower dosages, and I don't have to see them again because that durability has persisted.
That's amazing. And I did watch that video. So doctor, I want to ask you, how long do the effects of TMS last? What is the durability of TMS?
I would say that it depends. It's very, very personalized. I usually do not have to see somebody in 6 months to a year, like what a lot of the literature suggests. And it goes back to some of that personalized aspect that we've kind of addressed is we take a look at what's going on with you and keep in contact with you and communicate with you and let you know that we can see you back again as well if we need that. And depending on the insurance, right? Because I'm not really a cash based. We do have a cash rate, but it's a very, very low percentage of my business. I'm mostly insurance based. So it depends on what the insurance gives me. And I try to hold back some of the sessions depending on the patient, right? It's all on the clinical evidence. So I hold back so I can do some of the tapering as well. I want the durability. I want them to get better. I don't need to use all the sessions. I need to use the sessions that they need and then hold back. And so I can taper them in such a way so that I can have that longevity and that durability.
That makes total sense. Have you ever heard that TMS doesn't work?
Of course, sometimes TMS does not work, but I would say as a caveat is probably the biggest thing is because like insurance, if insurance says, well, you get 32 sessions because 30 is the minimum, right? Well, this person has been dealing with depression, anxiety, and PTSD for 30 years, and you give me 6 weeks, to make a change. And so that the rate limiting step is that. I'll give the best caveat is here in Colorado, right? We have a lot of marijuana users. So
yes, you do.
So the daily marijuana users that do not want to change, they want to still continue to do their multiple bowls a day or edibles a day. They do respond, but it usually takes double. My average for my daily marijuana users that do not want to change. Now there are some that taper or they rarely use, and it's okay, or once or twice a week. I can handle that. But if they daily heavy use, for usually greater than a year, sometimes it will take up to 60 sessions. But I get them to respond, and so to me, I think it's just the response is the compliance and what insurance kind of gives me, and that is a rate limiting step. And so here at FCC for the major depression disorder, we have a response rate of around 83%. So I still have 17% that do not respond.
Right. Are there any other common factors that you're seeing that surrounds the doesn't work question?
Yeah, so the what I've seen in both the literature and also in practice, right, is daily heavy benzodiazepine use tends to go down, and sleep. I teach at a few med schools and PA and NP programs, and I tell people all the time, number one thing is sleep. We have to get them to sleep. Right. So consistent poor sleep before TMS tends to decrease the efficacy for that. So we have benzodiazepine use, drug use. I mean, there's some other studies, I guess, in the UK, cocaine and stuff. If you have a cocaine problem, I'd probably get you off cocaine before doing TMS. But in general, there is still is there's a lot of other substances that we don't know too much about. The studies are like a case study or a case series. It's hard to base things when you have like 5 to 12 patients.
That actually brings up one for me personally. What if somebody's drinking alcohol? They heavily, I think would be the most important topic. If someone is drinking heavily but wants to go through TMS, what's your take on this, and how do you approach that?
Yeah, one is motivational interviewing. So remember, I'm an addiction guy, and so where does that person want to go? When do they want to stop? Do they have any engagement to taper? So like anything else, we can parallel process that. The seizure risk is actually when you stop drinking.
Yes.
So the first 72 hours. So, to me, it would be, well, what kind of alcoholic? Is this a binger? Then I'm a little concerned, right? If they just binge on the weekends versus, our working alcoholics, right? The ones that they function fully, but they drink a lot at night, maybe whiskey at night to get to sleep.
Yep.
It happens at times. But, it's really when they actually kind of stop is where that seizure risk goes. So a good medical workup, good motivational interviewing, and definitely you could definitely do parallel with that. Done that a lot, especially with alcoholics, because also it depends on what they want to do, because then I can do a benzodiazepine taper, right? And so there is a way, if they do want to stop, we can have a cross titration, just like we do if I was inpatient, right?
Wow,
and so,
yeah.
We use Cirax a lot. There's a lot of different kind of benzodiazepines that we use, or maybe some longer acting that we then titrate somebody over, and then we taper them down. So it's if you're trained in that and you've had exposure to that, that's usually very doable.
And I would imagine you've seen a ton of success with what you just said.
Yes, usually, but it goes to the old adage, right? How many psychiatrists does it take to change a light bulb?
Do I know how many?
How many psychiatrists does it take to change a light bulb?
I'm waiting for the answer on this one.
One, but the light bulb's got to want to change. So we have to work with the patient. We got to work with the patient.
Should have seen that coming a mile away.
Find out where they're at, and then work with them. I mean, and this is right. You meet a patient where they're at in a non-judgmental and agape love. Like you come through a place of love with the patient, and things work out.
That's actually beautiful. Well, it's beautiful. I love that. In one sec, Doc. Am I in order?
Yes, you are.
I am.
I'm not even looking.
You have me so excited. Like I said, I'll get lost. That was awesome, Doc. That was really awesome. And it really touches my background, right? So thank you for that.
Yes, sir.
How effective is TMS for depression?
So if you look at the meta-analysis, the old ones in 2012 were pretty weak, but I kind of wonder how much the statistical kind of significance of that was. Most of the meta-analysis that you see now, I mean, you can look in anywhere from a range of 30 to the high 60s. If you look at the the manufacturers of the TMS, they always have high amounts. Yeah. I kind of throw those to the side. And so in general, high 60s is usually what we see as far as a response rate for major depressive disorder, refractory, which means failing one med or one modality and having major depression disorder. And like I said, we've had, this is why we're publishing, is because we've had an 83% success rate with TMS. And it's just huge with our bilateral approach, and also our we use different waveforms. So we use I use both the normal 10 hertz as well as the theta bursts. And so we use these concomitantly.
Okay.
Yeah, I don't just do, I know it makes probably more business sense to just do theta, but I think that the best efficacy is using two different waveforms and basing it on the patient's symptoms and also their EEG.
Well, that goes right to what you were just saying about meeting the client where they're at, right? Because you are running those EEGs, you can see those things, can't you?
Yeah, not everybody gets an EEG because there's a lot of things that are pretty, I mean, the majority aren't that complicated, right? And they do respond. If I start seeing that they do not respond, then we go into the EEG. Now, the ones that are in the non-FDA, like less than 18, I pretty much all of them go through EEG. So
less than 18 years old, no matter what, you're getting the EEG.
Pretty much. Now, if they, if they really don't want to, if the parents don't want to, then I'll do the normal protocol. I do, like I said, I meet the patient where they're at. There's no dictation, but I'm like, I really strongly recommend this because it can dictate where we're going to go with this, because it really does help me. Because the biggest thing, there's 4 main waveforms, right? There's a lot more. There's gamma too, but we can't really touch that, right? And so when you talk about a theta, a delta, an alpha, and a beta, alpha is that 10 hertz. Alpha is prayer, meditation. It's the quiet mind. It's the happy place that you're trying to get. But actually, if you look at what the internal structures of the brain, they usually talk to themselves in 3 to 5 hertz. And so you've got to couple this on the location on the neural network. And so this is where I think that I have seen some of the best efficacy. So you take not only the EEG, but you also take our prevailing wisdom of what we've known and some of our anecdotal kind of experience, and then we kind of couple that together.
That's fascinating, honestly. It's really fascinating. Now, what about patients? It's something we see typed in all the time. What about the patients with dental implants? Does TMS work with dental implants?
99.9% of the time, as long as you've had it before like 1950, they're pretty much all non-ferrous.
Right.
You have the Army. I've got the T-shirt and the couple spinal fusions, whole airborne, air assault kind of thing.
Yes.
So, even those, the spinal fusions are usually they're titanium, they're non-ferrous, right? And so the biggest thing is going to be deep brain stimulations, right? Some of the newer cardiac actually has an MRI mode. And so I've done those on some of the newer, for, some of the newer kind of implants. Cochlear implants are pretty much a no-go unless they have that MRI site setting as well.
Okay.
And then, of course, because we do a lot, FCC, we first started with military first responders, military families. I see a lot of veterans. We're the #1 provider in Colorado for what we call the community care network. So for VA to send outside of the VA, actually Family Care Center we're #1 in Colorado. So
well, and you guys have a huge military population up there too, right?
Huge. Not only in the Springs, but we're in Denver as well. We have between the two, it's 5 and 12. I think that we have 16 or 17 clinics all in Colorado.
Wow.
And then the other ones are in Texas and Tennessee.
Okay. I like that.
So we're in 3 states right now. We're at 20 clinics right now.
That's beautiful. How many people are you guys seeing over all of them? Do you know by any chance?
Well, I think the last count, on average, we see about 5,100 encounters a week. In general, and almost close to 500 TMS sessions each week.
That's so big. That's awesome. That's so awesome. It's saving lives.
I want to make a difference in our community, and I got some investors early on, and I picked people that would allow me to have that clinical ability to continue. I've got a great executive team that we're moving forward, and they're making these things happen, because it took me 5 years to make 5 clinics by myself.
Okay.
Yeah, it was a lot of duct tape, a lot of definitely late discussions at night with the wife, right? No salary.
Oh yeah,
this was painful. So having partners that bring maturity and kind of can help me do this, but give me that clinical independence. It's a perfect marriage.
That's so important. That's so important, especially in business, right? It sounds like #1, you have this down. You have TMS down. You know what you're doing. Having a partner to come in and kind of try and dictate things on top of that is not a key to success, and is definitely not putting client first. And I've seen that too many times. So I love that you're able to operate in such a way. It's so important. Again, meeting the clients where they're at and giving them what's best for them, not what's best for our pockets, right?
Correct. And we hear that all the time. We're in here for the long haul, and to take care of the patients. Everything else will come in time.
Amen.
More, less than I deserve. So it's all happening.
I love that. I love that so much. So a big concern that I do have personally is taking antidepressants while receiving TMS care. Is there any concerns with the combination of the two?
I would say, after all these years, I would say no, I am not that concerned. When we have people that refer from the outside and their providers, you don't have to see us for your total care. I tell people use us like a buffet. So there are some med providers they send to us, or therapists that send to us, and they still keep their care. What we do is just coordinate. We coordinate them like, hey, when are those med changes? What's going on? Here we are at the processes with the PHQ-9, the HAM-D, the GAD-7. These are what we're kind of seeing with the patient. So keeping that communication going on with that primary prescriber is very, very important. Now, when it's internal, they're very easy to do, right? But for those outside providers, I think that there's a lot of TMS providers out there that they, fire and forget versus, hey, no, this is their primary provider. We have to coordinate care with them. And so to me, I would say, what are those med changes going to be? And then we talk about it, and never to, we acquiesce to what the primary provider is. We just want them to have all the information in front of them. So to me, a lot of the things are going to be like the benzos or some of the stimulants, right? And so when we're talking about some of the controlled substances, that's when I might just educate a little bit more on here are some interactions with TMS. But otherwise, I don't really see Effexors, Cymbalta, Prozac interfering with TMS or its efficacy. If anything, the great thing is we start to taper as we start to get down.
And that's, again, my thing too, is like reducing the meds as we're going through. It to me seems so important, right?
Well, I think
and
my main
obviously
goal,
there's people that can't do it and aren't going to be able to do those things, but in general, that's the real goal of this, right?
well, the real goal for me is change the behavioral system care. I really want the patient to get better, in that whole sense. And so if it's on minimal meds, less meds, no meds, that's all a win to me, right?
Yeah.
Is their life better on less of these medications, whether it's the less dosage or less number, or of course it's a total like yay whenever they're off all of them, right? And I have done that. So many times where people are off meds completely, and it's just incredible.
Are there any disadvantages to those who wait until after TMS to start changing the meds?
Not necessarily. I would just say is that, sometimes, and I'll tell you, this is I tell this to some of our PAs and psychiatrists that aren't familiar with TMS. There's been maybe out of, I think last year, I don't know what we saw, 125,000 patients overall, right? In all of our clinics, right? Maybe there's 20 to 30 that come to mind that they were getting some very odd side effects during TMS. And I was looking through the literature. It wasn't TMS. It was like some very odd things. And what you looked at was the meds they were taking. And it was not the top like 10 or 20. It was some of the bottom stuff that you see on the farm list, right?
Okay.
This is a theory. I don't have anything to back it up. And this is when I definitely tapered down the meds during TMS. I believe that there might have been more of an endogenous production, an inside production of your neuroreceptors because of TMS, that because you're exogenously taking these meds, it was too much. And the side effects were actually from the side effects from the meds being at too high of a level, right? So to say effects are for one reason. So, sometimes you see a lot of things, but people usually are a little jittery or have some palpitations. It goes away in 2 or 3 days and it's good to go. If they've been on it for 3 years and all these things start coming back, and restless leg syndrome, and they're like, what is going on? I'm feeling anxious. They're sweaty. They're getting red. You're like, this is not TMS. Like, we have to talk about reducing your effexor like now. We've got to get some of that norepinephrine down, because I think that the TMS is working and it's taking that over for you. Your body is producing that which you needed.
Yeah. Again, the whole point of doing the TMS treatment, right?
Yes, sir.
One question that I continuously see and is concerning to me, right? Can TMS make depression worse?
Make depression worse? No, I do not believe that TMS can make depression worse. There is something called, a drop, or they call it the bump, something that happens, the dip, I've heard it called a lot of different things. Remember, I take care of a lot of military, so I'm trying to keep the vernacular clean on here. Yeah. So regardless, the dip, or it happens somewhere around that 9 to 11 sessions is usually what I kind of see. And what I kind of tell the patients is, well, we've got to get through this, right? If
Yes.
anything, this is why we really spend a lot of time on that biopsychosocial spiritual, right? So, hey, let's work with your therapist. This is what's going on. Instead of doing that once a week, let's go in twice a week, right? Let's have you a little bit more hands-on. Let's have a little bit more approach. Let's have some goals that are a little bit different. Hey, let's reduce amplitude, let's change things for the patient to make sure that they are staying compliant. Because in the end, I think the biggest thing is continue with the treatment, continue with the process, trust that this is going to work, let your body heal itself. And this is what I'm doing. I'm supercharging your neurons so then it can take over and we can let you go.
Well, that's something to me that I've seen is people experiencing that dip and then stopping the treatment. How bad is that?
Well, it doesn't happen that often because one, we're pretty experienced. We're looking for it. We're asking them. Each day, our TMS technicians, this is the other thing I'm really working on is, especially as we've grown so much, I've probably trained more TMS techs in the state of Colorado too. And so we're really kind of creating a very formal TMS technician program. And actually we have a whole career pathway for them, actually.
Oh, wow.
TMS techs. And I cherry pick some of my best medical assistants or those that maybe have a psychology or a neuroanatomy background or an undergrad in those. And we really spend a lot of time. It's like a 6-week program where we are teaching the technician how to be a great TMS technician, despite whatever their medical background is. And so this is just one of those things that, hey, I'd like you to look for this. This is what you're going to be asking for. Right. And it's on the radar. If we know about it, it's the people that do, once again, the fire and forget, those places that are, that don't really look at the whole picture. I think they sometimes forget about this.
Right. One of the questions that we often see, and we know most people are struggling with, can TMS help with anxiety?
For sure. Now, one of the things that we have a lot of limitations here in America is that big machine that really limits the FDA approvals, right? And that machine is not the best thing for the patient. So I base a lot of our literature on the CE, which is the FDA for Europe, because they use TMS for everything. And so what I mentioned earlier, some of the things they look for cocaine withdrawal or even schizophrenia, most of those are European studies or Asian studies that are looking at these things because they don't have as many limitations as America does, right? Okay. And so what I've seen, and actually it's going to be it's our third paper that we're going to try to publish this year because I have such a huge amount of data for our general anxiety. So our protocol for general anxiety is around a 65% response rate. Okay. Which is better than any of our SSRIs that we can do.
Yes. Yes.
And we submitted a grant for doing a PTSD study as well, because our PTSD numbers are approximately about that same level as well. Getting PTSD signs and symptoms to be reduced.
That's amazing, especially with your population as well, right?
Yeah, but insurance won't pay for it. So it's always, they've got to have major depression disorder and a concurrent kind of diagnosis for me to do that. And unfortunately, because like I said, I just haven't built the cash business like a lot of the other places have. Yeah. And yes, I completely understand that. And we kind of did already touch on this a little bit, but I do see it as an important topic. And I do know that as it was for me, one of the biggest things that held me back from getting TMS was the seizure factor, right? You're in there messing with my brain. I don't want you messing with my brain. What if I have a seizure, right? Does TMS cause seizures? And there is a probability, there is a chance, right? And I think I mentioned earlier that 1 in 30,000 was the last study I kind of looked at. The Brain's Way, which I use for OCD, and really some very kind of deep kind of aspects, especially with when I have Tourette's and OCD, I seem like I've gotten some really good aspects with the Brain's Way because it goes a little bit deeper. It's a little bit stronger, but that probably has the highest seizure risk. And so I keep the amplitude down very, very low. So this goes to something else. I don't know how specific you want me to get, but most of the protocols go to 120% of your motor threshold. So just for your audience, your motor threshold is going to be that aspect that I'm moving your finger and thumb, the pollius brevis, the first index finger. What is that amount that I need to move it? And I want to use the least amount. So we really look for very minute kind of movements. And if you look at that, to see a movement is about 80 micro volts, right? But to actually create neuronal activity is only 30. So we don't even actually need to see it in the sense. So I can still create neuronal activity at a lower amplitude. And so I rarely ever go to 120%. And I still have these high response rates. And I have a higher compliance rate, and I have never had a seizure. Knock on wood. Because I don't go to the 120, and I don't ever go beyond that. But when I do, it's like, so even if the system or the protocol say 120% is kind of where you need to be, and then you just kind of go there, that's when you start seeing that there's a lot more side effects, less compliance, and of course that seizure risk. And there was a meta-analysis that came out, and I can't remember it off the top of my head who the author was, but I think they said when they looked at a meta-analysis, 108 to 112 was that sweet factor of both safety and response. And our average is 110. We usually do about 110%.
Yeah.
It's a real thing, but if you know somebody that knows what they're doing, then this is where the patients, like, I love what you're doing, like educating not only the populace, but patients, if they're looking for this. And also, if a provider's looking at this and they're doing what the book says or what the manufacturer said, they need to explore a little bit more. We are doing things with someone's neurons. You have to know what you're doing. If your mind does not know it, your eyes will never see it.
Amen to that. So something that has personally touched my life, as it does many lives today around the world, autism. Something that we've been watching very closely. And I have personally seen it, but I want to ask you, can TMS treat autism?
Yes, but it would be what symptoms, right? And so once again, if you look at the studies, they're very, very small, anywhere from 9 to maybe 20. I've probably done about 27 autistic patients, probably about a 90% response rate, but the response rate is different. So what you look at, and the literature kind of backs me up with this, is repetitive behavior, aggression, or self kind of destructive, like head banging and things like that. Those decrease significantly, right? Somatosensory really doesn't usually come back. And unfortunately, language does not come back. So what I usually see is aggression reduce. I see repetitive behaviors reduce. I see they get better response rate and ABA, and they're on less medications, especially since really a lot of my psych meds for autism, when I was talking about the poison things, they're really just trying to control some behavior, so they can get through the ABA, so they can get through their day, right? So the TMS is in complete augmentation for that. I think on one of the programs that I had, I talked about a very high successful rate with, especially when they get into puberty, right? Because their social disinhibitions, especially when we have somebody that has severe autism without language. So there's a lot of barriers that go with that. And their aggression really, really gets heightened. Their endocrine system is going crazy. The TMS can temper that in such a way that I can lower down some of the meds and make sure they stay in therapy and engage in as much of the highest level of their social kind of contact that they can do. And so I would say unequivocally, yes.
Thank you for that answer. Thank you so much for that answer. Another one that I've seen people turned away because of this, bipolar. People are against clinics treating people with bipolar. And I would like to hear from you why. Can TMS treat bipolar? Is someone safe receiving treatment with a diagnosis of being bipolar?
Again, yes. So treated hundreds of people that have bipolar or some kind of type, right? And sometimes they've been misdiagnosed, just put that out there. The thing is, it's the insurance. The insurance automatically deny if you have a bipolar diagnosis, right? So once again, just to tell your listeners and anybody out there willing to listen, the insurance is a huge barrier. So not only the FDA approval and the people that have said, hey, this is what it's authorized for, but to put some of those barriers. The majority of a bipolar's life is spent in depression. And so some of the protocols that I've used, it's along, if you know, on the EEG, so on the dorsolateral prefrontal cortex, on the frontal, usually there's both an F3 and on the right is the F4, right? And so this, sorry, we don't have a slide and stuff, but on this frontal lobe kind of aspect, sometimes it's a more medial approach that I've taken with the bipolars. Once again, somebody else smarter than me has done this, and I've kind of repeated it, but I still stay in that left side dorsolateral prefrontal cortex because it's the depression, right? I do treat the right side as well. I have yet to see anybody convert to mania, right? And so so that is always a question if somebody has bipolar. It's a fear, but my medications have more of a chance to convert somebody on, I don't know how many bipolars I see that are on a stimulant. I'm like, maybe they truly have ADD, right? But in the sense, it's like, wow, we're really playing with fire here, right?
Yeah.
And I'm turning things up when I'm trying to simmer things down with a mood stabilizer. And so, but once again, most bipolars stay in depression. And so TMS is wonderful at that.
I love it. Thank you for that. Thank you so much. As somebody who has 3 children, and I love my babies to death, 4, 9, 16. For some reason, me and my wife, we spread them all out. Is TMS safe for kids?
Yes, it is very safe for kids. Once again, not FDA approved for underneath 18.
Yep.
And we make sure, and of course, of the parents and the guardians, and depending on the age, I think in Colorado it might be 13, but we get consent, informed consent for everything. And I usually use a little bit lower amplitude. Or I also have, so we have a resting potential. So the time in between pulses or a train, sometimes I have expanded, depending. But I will tell you that the lowest age I've done is 9. But with great response. Failed multiple medications, in and out of residential, in and out of inpatient.
Wow.
Yeah, does TMS and is on lower medications and has stayed out of residential, right? And actually, she is one that she comes back about once every 6 months.
Okay.
But not for a booster, just for one session.
Just one tap.
Well, one session, one.
Yeah.
Well, it's a 30-minute session.
But that one session is changing this child's life, and preventing things down the line that obviously only God will know. But I mean, as somebody who comes from a background similar, I praise you for it. I truly do. It's one of my biggest things is I wish, man, if TMS was around when I was that age, who knows where I would be today.
It goes to the ACEs, right? The adverse childhood events. If we can do something at a younger age, and I think the neuroplasticity is so robust, right? That we probably should explore that a little bit more. My medications, and there's so many side effects, right? And I don't want to hurt the liver. I don't want to hurt their kidneys, right?
Of course, yes.
And I think this is the most natural kind of holistic way to do this, right?
Yes. It drives me mad because it just makes sense to me, right?
It does make sense, but insurance will never approve it. In fact, I've had some, they're like 17 years and 11 months, and they like call us back in a month. I'm like, are you kidding me?
Jeez.
Like, are they really going to, their whole body's changing in 1 month? I'm like, okay.
I personally know a doctor, and she says it's amazing how they practice medicine without even seeing this patient.
Yeah, it's that's actually a whole other.
Yeah. 100%. So I was recently up in Colorado at the Clinical TMS Society conference.
Oh yeah, I think I saw that video. Yeah.
And we saw some interesting devices that looked like they were coming down the pipeline. And my next question is simple. Can TMS be done at home?
I think right now the technology is not there yet, because I saw that I was there too as well. In fact, I probably had more people. I think I brought 50 of my providers there.
Oh, wow.
So yeah, we were in force there.
Yeah, you were.
Well, I mean, it's home, right? It was spring. So I brought some Denver people down, and things like that. But you know, I'm not sure that we're there yet. There's a you know, like is it like a transdermal kind of response right now? They're working on a migraine. That might be the first in-home thing that I actually see would be actually working, because if you didn't know, or your readers didn't know, it actually does improve migraines.
Right.
And so TMS treatment, people always say, oh, it's going to make my migraines worse. No, it actually makes
No,
frequency, intensity like less. It does. There is a chance tension and cluster headaches could possibly go up until you get used to it. But the migraines usually get better. So this migraine in the vertebral basal is really exciting to me. So I think that'll be the first at home. The problem is the location, right? And so if we had something that Star Trek that had the EEG and did all the robots, is there a chance? Yeah, but we're not there yet. And I don't know if you stayed for the whole clinical society, but they're really pushing down this directed like robotic arm, which doesn't make sense to me, because they're not basing it on EEG findings or even neural networks. It's basically just their skull size. It's where is the F3? Well, I'm sorry, a monkey can do that. I mean, we do the F3 method, and I have a FCC way, and then we have the 5 centimeter way. There's a coupling that goes along with that, right? But I'm like, that's not how it works. This is not a sniper bullet, you all. We're hitting this whole area, whether you like it or not.
Yes.
We're hitting the neural network. This is, I've met with Anthony Barker. Like he even said, that's not how the technology works. He made the first machine.
Yeah. Well, it's so important, right? So is there any other issues with it going to the in-home personalized care other than we aren't there yet? One of my biggest concerns is this something that you want to do on yourself? Are you bringing someone in to do this for you at home? Things of that nature.
Yeah, I mean, I think, of course, if you're messing with your head and could you cause a seizure and there's nobody present, yes, that would be a very, very bad outcome, right? That would set TMS back, decades, right?
Yes.
I actually, before I got some investors stuff, I actually had a TMS van, and I was thinking about mobile kind of units, but I could never get it past the insurance. Once again, the cash guy.
Good old
guy. I mean, we have a poverty rate. We do have I know one of your questions are cash rates. I don't know exactly what they are. Somebody else does that, but we have like a double poverty scale. So we make sure that people that do have to pay cash or is the most affordable possible. But like I said, most of my business is insurance, but I couldn't get the insurance to buy off on this mobile TMS, even though they did it in LA with a nursing home. And actually that kind of I think it was 2015 or something, but
we do have some out here currently.
Yeah.
I'm familiar with the mobile TMS, not only the business model, right, but it actually running and seeing people again, meeting people where they're at. Again, it is more of a cash pay model, where they're seeing the success and the ability to treat people. But yeah, everybody has that problem with the almighty insurance company saying no, right?
Yep. Yeah. You need to be academia or have some kind of grants. And I'm working on that. We have a researcher now, Dr. Sabrina Segal. And so she came on board in April. And she says, I'm allowed to tell this story.
Okay.
All right. So she worked for Stephen Stahl. Do you know who Stephen Stahl is? Dr. Stephen
I'm
Stahl?
not familiar.
You can look him up. I studied him in residency. Every psych resident studies his psychopharm books. He's probably one of the most learned psychopharmacologists in the world. Like Stephen Stahl writes the books, literally, right?
Okay.
He also is on every drug rep. So when his disclaimer, it is every drug company, right? And so she's worked for years as one of her main researchers for that.
Okay.
Well, I treated her husband, who had both MDD and PTSD, and got him off all of his meds, and he has been without meds for over 3 years now, and never come back for another session. Wow. So he's another success. So she actually reached out to me and said, "You don't know this yet, but you need me." And she's told herself, and I hired her on the spot. She's amazing. And she's the one helping me. Like I have all this this data, but I haven't done anything with it. I just don't have the time, right? Or probably the intellect. So I've got somebody, just like anything else, you hire people that are smarter and better than you.
Surround yourself with the best, right?
And she is the best. And so that's how we're getting these publications going through. She's getting through the data that we've collected for the last 7.5 years since I retired, and we're making it happen.
That is awesome. And will help advance TMS, which is the ultimate goal, in my opinion. That's why we're sitting here today, is to advance TMS, right?
Yes, sir.
So with that, you've talked a little bit about this in several questions that I've already asked you. What are the requirements for TMS treatment regarding insurance?
Yeah, so each insurance, they kind of throw their own barriers up, right? So FDA is major depression, treatment resistant, failing one med or one modality, and over 18, right? So that's the FDA.
Over 18, yeah.
Now, what the insurance have done is they say 2 to 4 meds.
Yep.
Usually, there's a couple that they've actually changed. I can't tell you which ones completely. I think Medicare has only one failed med. I think that they're the ones. Medicaid does not pay for it yet, except for, I think, in Washington State. I believe one of my colleagues told me, but I'm not familiar with that. But so 2 to 4 meds is a failure of what people usually look at, and then some want augmentation, some want psychotherapy that goes with it. The good thing is, usually by the time people get to us, or are thinking about TMS, we have actually, they've already failed easily 2 to 4 meds.
Right. The gambit anyways, right?
Yeah. Yeah. And so, I have seen some of I won't mention the name, some of the big players that they've kind of recently, they have to fail all these meds in this episode of care. I'm like, this has been going on for 6 months. I'm not going to change 4 meds in 6 months.
Exactly.
That doesn't make sense. So, and once again, it's going back to that statement you said, like, are these people do they actually practice medicine? When you do a peer-to-peer, I'm talking to another psychiatrist.
Exactly.
And we're talking. If they're just reading the manual, who Lord knows who wrote, then we've lost that peer-to-peer. If they're actually a physician that cares about patients, then we can usually get them approved.
Wonderful. And I don't know, I know you have clinics all over, but what you have stated, you're mainly an insurance-based business. Where do you see the cash pay? People who don't have insurance, people who have insurance policies that won't cover TMS, where is the price point falling for TMS?
I mean, I've heard some outrageous numbers. I've heard of over 10,000, right, for 30 sessions. I don't think I've ever charged that and stuff. It's all over the gambit, right? I mean, if that's why I hope to get some of these grants, so then I can have grants to pay for those kind of things. I hate that we even have to collect copays. I tried to get no copays.
Yes.
And I was told by the insurance, if I did that, then they will cancel my contract.
You're breaking the law.
And then here's the other thing is, just to complain a little bit, like some of the government contracts that I have, I'm a TRICARE, I'm a VA kind of thing. Even if they got disapproved, they can't pay cash because it's one of the rules, because they are a government payer. I'm like, who put these rules into place? So if you were United, if you got denied, you could pay cash, but these people can't. I'm like, they're my people. They are your brothers and sisters, right? And
they are specifically your people.
Exactly.
It has to be extremely hard.
It infuriates me, actually, but yes,
I'm sure
that's where we're at then.
So
hopefully there's the populace and the people, when they see that, hey, TMS is working, this is great, get me off meds, maybe they can help change some policy. I'm not really sure.
Well, it's a fight that I think we're all willing to try and fight, right? Sure. Can TMS can we do talk therapy, while continuing or while doing TMS? Let me give you that one again.
No problem.
Can I continue therapy while receiving TMS?
Well, how do you feel about that?
How do I feel about it personally? I'll tell you, personally, when I went through TMS, I was driving an hour and a half to receive TMS when I did mine, and I did 40 sessions, right? It was an hour and a half one way. I had to get, I work, I'm a self-employed guy. I had to get back to my companies, So I called my therapist. I told her, I'm going to go do TMS, and I can't see me making my appointments too. And she said, Kyle, let's pause. And that's what we did. Now, do I wish I did that? No.
Yeah.
But you're the doctor, and that's why I'm asking you the question.
Well, this is the other reason why I created FCC. I really do believe that family care center, I mean, each one of our clinics has about 10 talk therapists, ranging from, registered play therapists to individual to group to DBT, all evidence-based, right? And med, so psychiatry, nurse practitioners, PAs, and 1 to 2 TMS machines. And so it's all underneath one roof, so you don't have to worry about that.
Right.
So I actually, what I've seen, it's actually going to be another paper, is our system of care, I think, is really driven and helped increase the efficacy of TMS. It's because, where I said, like I mentioned a little bit earlier, my real goal is to change the behavioral system of care. These demarcated, siloed systems where we're not talking, I think really is a travesty, because I mean, behavioral health, mental health is so complex. And it's actually why I changed from flight surgery in the Army to psychiatry, is because it is so complex. And we do need so many vocations. And I love tapping into other people. And I love the energy that comes together when you are getting all these people to focus on how do we get somebody better. And that's why I wholeheartedly believe in the biological, psychological, social, spiritual model. I truly believe when we put all these things together underneath one roof, we get a better system of care. And so this is where I see us going. So yes, therapy, continue it. If you feel like you need to pause it because of time or something, okay, but have that as a discussion. Maybe you can go once a month or something. Maybe there's a check-in. But there has been some literature on EMDR, right? And so with trauma work, but I haven't seen a decrease on efficacy of that. Usually this comes from providers from the outside of FCC that are concerned. And so some of it's a little bit of education on them, like, no, you can still continue to do this. Would you like to do it after, before, whatever it is? I ask consistency, because if there are things going on, especially with biofeedback, you definitely want to make sure that we have a pretty consistent, because people's whole rhythm changes, both with TMS and also just naturally throughout the day.
Yeah. I love it.
Come on, I thought you were gonna give me a hard question,
man. Well, here it is. The most common asked question, the most commonly typed in question: who does TMS treatment near me?
This is where we spend a lot of time on how do we get the word out and how do we get to these other locations. Now, my focus and the focus of our board and stuff has been, we call it both NFL cities close to military posts or bases, right? And so we're in Austin, close to Fort Hood, right? We're in Nashville, close to Fort Campbell. I'm going to go to Tampa, close to MacDill Air Force Base. And of course, we're here at Carson and Air Force Academy and Peterson and Schriever Airport, so NORAD. So Colorado is an easy one. And so it's really, this is where the behavioral system of care, because I hope that we get to all these states, right? But if we don't, that people look at our model and say, I want to mirror that, and hopefully if they're mirroring the model and the system of care that we're doing, it's replicating in a different way. And we're still helping the community. So I both want to expand FCC, and I think we deliver the best care, but we're not the only ones. And so I hope people look at the behavioral system of care that we're delivering and then try to replicate that. And then we're going to have a lot more TMS providers. We're going to have a lot more synergistic treatment centers for behavioral health. And we're going to get away from the demarcated, ones and twosies.
Well, and that leads me right into how does one identify a good clinic? Obviously, everyone doesn't have the ability to go to FCC, right? Which I want to circle back and touch on. But what should someone be looking for when typing into Google, right? TMS near me.
Yeah. So what I'd look at is, there are some places that are standalone. They only do TMS. And so I would not only question them, I say when the patient is educated the most, and there's a lot of good stuff, there's a lot of bad stuff. I love your stuff. So we get them to look at your YouTubes. I think they're going to be educated a lot better, right? But stay away from Wikipedia. But at least to go educate themselves so they can ask some hard questions to the
Yeah.
providers, making sure. But then if they're just going to a standalone, how often are you going to communicate to my therapist? How often are you going to communicate to my prescriber, right? And if they're like, well, we'll tell them something at the end. No, that's not coordination of care. And of course, if they're failing answering the questions, or it seems like they're hemming and hawing, then of course goes to somewhere else.
So a prescriber in office is something that is important with the TMS center. You would say?
I think so, but there's a lot of places that are standalone, just TMS, and they're awesome at it. They just have to have that coordination of care, right? And making sure that they communicate and they're not in a silo. And then there are some that are synergistic with it, and the thing is that they're rare out there. That's why I actually did this, because I was like, I didn't see it very often. In fact, when I looked, I think it was less than 10% of all behavioral health is kind of delivered like FCC delivers it. But there are some good standalone places out there. Just make sure they communicate, and they know what they're talking about.
So first and foremost, I've truly appreciated you sitting down and talking with me today. I do want to personally thank you for your service to this wonderful country. And then to continue that service in such a needed way. And how you were able to transfer military to TMS, man, God bless you. That is so wonderful. And I can only imagine how fulfilling that is for you, So thank you. And I commend you for that. Do me a favor.
Yes, sir.
Tell my listeners where they can find your stuff, where they can find your content.
So fccwellbeing.com is our website. We have a TMS page. I think I've made about 13 videos on frequently asked questions. Some of them that we've kind of discussed, they're very short, maybe 30-second, just trying to get somebody to understand a little bit. We just hired about a month and a half ago a VP of marketing. And so, we're starting to make our YouTube. I have some very old stuff. I have some stuff that was done on a camera, right? So, like a video thing. So I'm not as professional as you, but I think we do have a lot of things out there that we're trying to really expand. And now that I have so many psychiatrists, so I think we're at 19 psychiatrists, right? And so we have a pretty, the largest private practice, of course, in Colorado for psychiatrists, and then all the nurse practitioners and PAs. And we've really done a great job of educating them. And so reaching out to any of those providers, or if you're taking a look on our webpage, you just ask a question. There's a little button there. You can ask a question and we'll get back to you. We'll do a free consult, even tele. Even if you don't want to see one of our providers, that's fine. I can answer your questions, or one of our great providers can answer their questions. So fccwellbeing.com.
I'm sure that they're able to run their benefits through all of that and make sure that their insurance will cover FCC's treatment and all those wonderful things right there, right?
Yeah, we have a huge, we have got a great TMS operations director, and she is amazing. She's transformed the business to make it more streamlined. Once again, hire smart people than you, and she's
That's
one of them.
right.
So she's amazing. So we'll figure all that out for the patient. They don't have to do anything.
Hey guys, if you found that video informational, want to see more, do me a favor, click this video right here while I enjoy my TMS sessions. Did you click it? Click it already. TMS, it's life-changing. This video right here is going to help you.